Today I am going to discuss animal poisoning in children. Animal poisoning is one of the common problem which we deal, especially for children who are staying in tribal areas and in Konkan and on all those children who stay in jungles. There are five common animal poisoning which we are commonly come across. One is snake bite, another is scorpion bite, bee sting, spider bite, and centipede bite. But commonest out of them are snake bite and scorpion. Let us start with a very interesting case. This was a 12-year-old female child who was brought in emergency room in an unconscious state at 6 o'clock in the morning. History said that she was absolutely fine previous evening. She was playing, had her dinner. There's no history of fever, convulsions, and head injury. No history suggestive of any systemic involvement. And early in the morning, the parents tried to wake her up and found that she was unarousable. On examination, she was afebrile, pulse was 100 per minute. Then the respiratory rate was 16, little shallow. BP was 80 by 60. There were no meningeal signs. The pupils were normal, central equal reacting to light. ENT examination was normal. CNS, there was no focal neurological deficit. Reflexes were sluggish. Planters not elicitable. She was not responding to even deep painful stimuli. CVS-RS per abdominal examination was investigation. The blood sugar was 92. Her counts were 6,200. HB was 12.2. Then MP negative, urea, HGPT, everything normal. Her WBCT 20 test was also negative normal. On detailed examination, we found that there was a doubtful fang mark which was seen on the left foot. So this was a farmer family and they were staying actually in the farm. The child was treated on the lines of snake bite, though there was no definite history, and was put on ventilator. She was given atropine, neostigmine, and she gradually an anti-snake venom, and then she gradually improved. The bottom line is that snake bite remains one of the very important differential diagnoses for unexplained unconsciousness, especially noted early in the morning in our area. This is classically called as EMNS or early morning neuronal shock and very commonly seen after snake bite. So snake bite is very common not only with us but also globally. So just to give some figures, around approximately 1.2 to 5.5 million snakebite occur all over the world every year, out of which 4.2 lakhs envenoming occurs because many of the snake bites are non-venomous. Approximately 81,000 to 1,38,000 deaths occur due to snake bite. 3 to 4 lakh suffer from disability. WHO has passed a resolution that snakebite is a global health priority because of such a high incidence of snakebite all over the world. WHO has also added that snakebite should be added to a list of neglected tropical diseases. And therefore, WHO is developing a global plan of action against snakebite. India is reported to have maximum snakebite death all over the world. Now, this is important. Now, if you see this map on global statistics, you'll find that the darker area is the one which represents the South Asia, Southeast Asia, India, indicates maximum number of envenomings per year that we have seen. So in India, approximately 100,000 people are beaten and around approximately 11 to 14,000 die per year, and out of them 20% are children. And the reason is that still many of the tribal areas stay in such kacha house, and there are a lot of jungle surrounding their area, and snake are very common with them, and many of them consider snake as god, and they play with snake right from their early childhood. Medically important snake, there are approximately 3,500 species of snakes all over the world, out of which 300 are poisonous, and in India approximately 216 species are there, out of which 52 are poisonous. But there are five important species which are medically significant. One is colubridae, second is atrapidae, third is elliptidae, viperidae and hydrophilidae. Out of which four are supposed to be very important. They are called as big four. So cobra or king cobra, second is common krait, third is Russell's viper, and fourth is saw-scaled viper. Now this is actually an old concept that these four are considered to be the major one. Now the concept is that even two important snakes like the hump nose white viper and Shochurex scaled viper are also very common, and now therefore the importance of that lies in the fact that ASV which we have traditionally have the antivenom against these big four. So now it is said that the ASV should be changed and we should have an ASV which we should have antivenom against these two again also, so that it should be antivenom against six. So these are the six common snakes which are poisonous, which are found commonly in India. This is cobra, the classical one, which a fang and the mark on the back of the fang. This is common krait. This is banded krait, another variety of krait. This is Russell's viper. This is saw-scaled viper. So the point is that many times invariably we get in OPD that many patients bring the snake which has been killed along with the patient, and they invariably ask you, doctor, is this a poisonous snake or a non-poisonous snake? So can we differentiate between them two? Yes, we can. So if you see the ventral aspect of the snake, and if you see that the scales are double row like this, so it's a double row, then usually it's a non-poisonous snake, and if it's a single row, then it's a poisonous snake. The poisonous snake, the body is usually thick, and there is a rattle at the end, and the head is broad. While non-poisonous snakes, the body is usually thin, they have a narrow head, and they have a pointed tail, there is no rattle. Even it is said that if you have the pupils of the snake, if they are rounded one, it is usually non-venomous. And there is a snout at the there's a rounded snout in front, and in case of venomous snake, the pupils are usually elliptical and there is a heat sensor pit in front. But the most important point is the fangs. The poisonous one have two big fangs, two major fangs, while a non-poisonous one has fangs like small fangs like this, while a two big one in case of poisonous fangs. It is said that what the venom does, venom is said to be in 80% enzymatic and remaining is a non-enzymatic one. It's a combination of enzymes which contains hyaluronidase, then digestive hydrolysis, phospholipases. Non-enzymatic portion contains polypeptide toxins, nerve growth factors, glycoproteins, metalloproteins, lipids, etc. But there are two important toxins called as presynaptic beta neurotoxins. They are called as chrotoxins, which block the acetylcholine release, and there are postsynaptic alpha neurotoxins which are called as bungarotoxins, and which also blocks the ACTH. The pathophysiology is that there is an increased vascular permeability in general. There is a tissue necrosis because of myotoxic or cytotoxic factors and hyaluronidase. There are some autocoids which cause profound hypotension. Then there are subtoxins which directly cause the damage to the renal tubules. Then there are phospholipases, there are neuro and cardiotoxicity seen. Lysothinases, hemolysis is seen with that. Then neurotoxic polypeptides or PLA2s of the snake venoms cause paralysis by blocking transmission at the neuromuscular junction. And then there are some myotoxicity like PLA2 myotoxins and metalloproteases are principally responsible for myotoxicity. And basically the principle is that there is, because of the toxin and venom, there is an increased capillary permeability. Clinically, There are five groups of snake presentation. Like the child can have snake bite and present in five groups. One is usually a local fang mark. So many times the parent comes and bring the child and saying that these are the marks and there is a doubtful history of snake bite. Otherwise the child is playful, the child is not having any symptoms. So mostly this is a non-venomous or a non-poisonous snake bite, which is very common. Second group is the pain. Crate, remember one very important thing, crates are painless. Other snakes like cobra and other Russell's viper are painful. They can cause swelling, ecchymosis, local bulla, bleeding, serosanguinous discharge from the local site. So these are sites, these are the these are the group which presents with these type of pain and local site system things. Group 3 is the one in addition to local, there are some systemic envenoming features like there's a fever, headache, muscle cramp, etc. Group 4 is the signs of extreme anxiety. This is very important. Most of the time, the parents come and bring that they are very anxious and they say that my child is going to die, or the parent, if the child is the elder one, the child says that I have got a snake bite and I am not going to survive. So they have got extreme signs of extreme anxiety. There is tachycardia, pallor, nausea, vomiting, colicky pain, sometimes loose motions. So these things and numbness, paresthesia, these are seen in case of as a sign of manifestation of extreme anxiety. Sweating, sometimes even vasovagal shock are seen. And then lastly, group 5 is the signs related to first aid. So invariably there are some friends or some relatives who apply tourniquet or some local things like some applying some herbal medication. So all the side effects and unwanted effects of these local treatment are seen as another group. So these are the common manifestations of snake bite. Now these are the local fangs. These are the two types of, as we have seen that there are two types of bites which are commonly seen. If these are two big fangs are seen like this, then this is mostly a poisonous snake. And if you see multiple small fangs like this, then it is usually a non-poisonous snake bite. And these are some local manifestations, like this child had a bite and then because of which the child has serosanguinous bleb, formation of bleb, and sometimes you get a swelling like this, or sometimes an edema, or some ecchymotic patches, or serosanguinous discharge from the bite. Symptoms can be CNS, it can be divided as per the system like CNS, CVS, or just gastrointestinal pulmonary system. Central nervous is CNS, you can get fainting or there is increased thirst or headache. Then systemic, one can get fever and severe pain in abdomen, and severe body ache also. The child can have the breathing difficulties. At the site of the wound side, one can have bleeding, then fang marks, discoloration as we have seen. Then there are other sites also, one can get ecchymotic patches or other sites in the body, on the body. Then the child can have blurring of vision. Then the child can have convulsions, loss of coordination, nausea, vomiting, diarrhea, intestinal. There are some symptoms like related to extreme anxiety also. Usually, if you classify, cobra bite are usually said to be neurotoxic, and the commonest toxin involved is called as bungarotoxin, which is in case of cobra, and they usually present with neurotoxicity like ptosis, diplopia, respiratory paralysis, mydriasis, hypotension, and ultimately the child lands into unconscious state, and sometimes the child have gets the cardiorespiratory arrest. Another common as we have seen is crate. They are also neurotoxic. They have, but the toxin is supposed to be crotoxin, which is a presynaptic toxin, and again present with same, that is diplopia, ptosis, dysphagia, respiratory paralysis, mydriasis. They become unconscious and then cardiac arrest. Russell's viper usually are either hemotoxic or a neurotoxic, can be a mixture of both. They present with pain, generalized at the site, and then ecchymosis, blisters, necrosis, GI bleed or bleeding in the mouth, hematuria, hypotension, and even acute renal failure. Why saw-scaled viper usually present with pain, ecchymosis, bleeding, but they are hemotoxic. So on an average, it is said that cobra and crate are usually myotoxic or neurotoxic, while saw-scaled viper and Russell's viper are usually hemotoxic. The two important things which I want to mention here is that, remember, crate bite usually do not have local tissue damage or local pain. So invariably many times the parents come and say that mostly the child has got bite, but there is no pain, there is no local reaction. So it could be still be a crate bite. And another thing is Russell's viper usually present with late renal complications. So we have seen children presenting after 48 hours or even 72 hours having acute renal shutdown after Russell's viper. So it is better, the point to be remembered here is that one should not make an hurry to discharge these patients of snake bite because they may have late presentations afterward. Ptosis is a very early sign that we have seen, that many times ptosis is seen and it indicates that the child has got a neurotoxic bite. Investigations, there are various investigations like CBC, PBS, but the commonest and most important investigation is 20-WBCT. This is a bedside test called as 20-WBCT. We are going to discuss it again. Then coagulation disturbances can occur, and therefore there is increased PT, PTTK, BT, CT, and fibrin degradation product D dimer are increased. LFTs are deranged. Then one can have myoglobin RFTs are also, especially as we have seen in Russell's viper and HN viper, that they can have an acute kidney injury. Immunoglobulin studies or ELISA can be done, but usually not commonly done, and X-ray and ECG are done as a basic investigations. 20-minute WBC whole blood clotting test is a commonest bedside test which is done in case of snake bite. So what you do is that you take around 5 to 10 ml of blood and take in a special container like this, and then the containers are kept along with the watch with a alarm of 20 minutes, and at the end of 20 minutes you invert the bottle. If there is a flow of blood, free flow of blood, then that is called as a positive test. And if the blood doesn't flow, then it is said to be a negative test. So it is one of the very important bedside tests in cases of diagnosis of. So 20 minutes whole blood clotting test or WBCT is one of the important tests as a bedside test in cases of snake. Now we come to the management of snake bite. There are various guidelines, especially WHO has given various guidelines time to time, and even Indian national guidelines are also there for management of snake bite. But the management consists of three important things. That is, one is first aid, then second is immediate management, and third is specific management. The Indian National Snakebite Protocol is said to be said as a RIDE protocol, a very simple, short protocol. For this is actually for first aid. It says that R is reassurance and relieve the anxiety. I is immobilize the limb like a fracture. This is called as PIM method, that is pressure immobilization technique, where pressure should be given at the site of bite and the limb should be immobilized like you immobilize in a case of a fracture, and get to the hospital as early as possible. Traditional methods have got no role and tell toxic signs, that is ptosis, etc. to the doctor. So this is called as the RIDE protocol, which is given as Indian National Snakebite Protocol for first. The important thing to remember in first aid is that you must reassure the child, reassure the parents, allay the anxiety. Almost two-thirds of the bites are non-venomous. They are called as dry bites. You are 100% you are going to recover. Mostly, even if you think that this is a poison, when you tell them that the parent that this is a non-poisonous bite, you are going to recover, because anxiety itself can cause hypotension. Excitement increases the heart rate and can spread the poison. Remove the shoes, rings, watches, tight clothes. Immobilize the limb, as we have seen the PIM method, that is pressure, pad, and immobilize. Place the affected part below the level of heart. This is very important. Many times they elevate the limb, so that should not be done. Clean the wound with sterile saline and dress it. Arrange to shift to a nearest hospital, and if possible get a photo on mobile, so that that photo can be of the snake and even of the patient, the snake, that can be sent to the treating physician at the referral hospital. And all patient must be admitted at least for 24 hours, but even 72 hours it is said, because late onset symptoms are well documented in many Russell's Viper bites. There are some don'ts in the management. The first is don't incise and wash the soap. What we do, this is a very common thing, that they wash with the soap or they incise at the side. Don't do that. Don't suck, do not quatre, do not cryo the wound, do not infiltrate ASV around the bite mark. So this is another common thing that we've seen, that they inject, enthusiastic people, they inject the ASV around the bite mark. Do not apply local ointment. Do not give drinks like alcohol or some Ayurvedic drinks. Do not catch the snake, or do not waste your time in catching the snake, because first thing is you have to take the child to the referral hospital. Do not apply tight tourniquets. This is very important. There are a lot of controversies regarding application of tourniquet. Many people say that there is no rule. Some people say that a light tourniquet may be helpful, because the poison spreads through the lymphatics and not through the blood. Do not burn the wound, and do not use the snake stones. Like there are some stones which are available which can be used to treat this, but this should not be used, as these things, they have got no use. Immediate management, a rapid clinical assessment is done immediately the child enters into the emergency room. So after that, establish an IV line, urgent resuscitation, that is AVC of resuscitation, treat the hypotension, oxygen for asphyxiated patient, treat the allergic reactions, angiotic edema. Many children present with bronchospasm, so treat them, give tetanus toxoid. Broad spectrum antibiotics should be given with an anaerobic cover, because we don't know in which dirty condition the snake was. Paracetamol should be used as an analgesic. Avoid aspirin. Treat vomiting and take the care of the wound. This is very important. Now, specific treatment is anti-snake venom. Species-specific anti-snake venom are some places available at some places, but they are very costly, very important. But the main problem is that it is not possible to diagnose or what type of snake it was. Was it a cobra? Was it a crate? And if you don't have a classical picture, or if you don't know, then there's no point in using a species-specific antivenom, and it is not available also. And therefore, a polyvalent antivenom, which is equine, which contains antibodies against four major things, like as we have seen, cobra or common crate, Russell's viper, and Sosket viper. So these are the four major one against which the ASV is useful, and it contains the antibodies. It is an equine variety, equine type, which is available. And now we are the investigations are, or the people are investigating, that can we use, or can we make a production of synthetic antivenom, so that if it is available, then you can have variety like four specific antivenom, or the one which contains against six snakes. So what are the indications of ASV? Do we give ASV to every child? No, we don't give, because we know that more than 2/3 of the bites are non-poisonous. Only when the following manifestations are there, like if suppose there is an extensive swelling, blistering, or bruising of the limb, or rapidly increasing swelling of the affected limb, or there are lymph node involvement which is significantly noted after the bite, or there are hemostatic disturbances like bleeding or shock, the serious manifestation like shock, hypotension, pulmonary edema, or CNS manifestation like impaired consciousness. Ptosis is a very important thing, which indicate that no, the patient has to be given ASV, or the patient has acute kidney injury or hemoglobinuria, or the 20 WBCT, that is 20-minute whole blood clotting test, is abnormal, or there is an abnormal BTCT or renal failure. So if these are the certain indications where you can use ASV. What is the actual role of antivenom, and what do the very commonest thing, that invariably, as it's a equine product, then the child usually get anaphylaxis, and therefore what to do. So the thing is that if there is this is a chart which tells us that if it's a no envenomation, or you don't find that there's only bite and there's no envenomation, then in absence of local and systemic reactions and fang marks, you should not give any anti-snake venom. Now, if it's a mild envenomation, then or you see a fang marks or moderate pain or minimal local edema, erythema, ecchymosis, or there are no systemic reactions, then you can give up to 5 vials. If it's a moderate envenomation which shows that there is a severe pain, moderate local edema, erythema, ecchymosis, systemic weakness, sweating, syncope, nausea, vomiting, anemia, then you can use 5 to 10 vials. And if it's a severe envenomation, then with fang marks and then severe pain, hypotension, paresthesia, coma, pulmonary edema, respiratory failure, then one can use around 10 to 20 vials to start with as an snake inject the same dose of venom into the children and that into the adult, and therefore the dose of antivenom is same for children as that for an adult. This is very important because invariably we get called that, sir, this is a child, just a 6-year-old child, should we give the full dose or half dose? Decision is taken of whether to give repeat dose or not on repeated clinical assessment. 2 vials are given usually 2 to 4 hourly initially for 6 hours, and then 2 vials every 12 hours to 8 hourly, and usually a maximum of 20 vials. Many studies says that adding more ASV may not be that effective. So this is very important. ASV is available from Hafkin and Serum Institute of India. Each ml of ASV neutralizes 0.6 mg of cobra venom, 0.45 mg of crate venom, 0.6 mg of Russell's viper venom, and 0.45 mg of saw-scaled venom. Anaphylaxis is the commonest thing, as I already told you, that it's an equine product. Many children get anaphylaxis after the first dose of ASV. So anaphylaxis, the important thing is one must expect that the child is going to get anaphylaxis. So expect that the child is going to get anaphylaxis and be prepared for anaphylaxis. The anaphylactic reactions can be of two types, or early reactions or pyrogenic reactions or late reactions. Approximately 0.3 to 81%, you can see the range. 81% of the children can get anaphylaxis. So one should be prepared to face such an emergency. Anaphylaxis should be managed by IV fluids, injection, adrenaline, hydrocortisone, oxygen, antihistaminics. ASV should be stopped till the treatment of anaphylaxis is going on. But remember, as soon as the child recovers from anaphylaxis, ASV must be continued. There is no option for ASV, so it can be restarted after treatment of anaphylaxis. Patient improves dramatically within minutes to hours after ASV. Prior skin test, in spite of the fact that many children get anaphylaxis, prior skin test is not recommended because it is said that you should not waste time in testing for ASV. So how do we manage the neurotoxic manifestations leading to respiratory paralysis? There is a scoring system called as a National Snakebite Scoring System for assessment of the neurological assessment after snakebite. And there are 5 points. One is the single breath count. So ask the child to say 1, 2, 3, 4, 5, 6, 7, 8. So this is called a single breath count. If the count is less than 10 to 15, then it is said to be positive. Then second is the millimeter of iris which is covered by eyelid. So as we have seen that the ptosis is one of the common manifestation and the child gets ptosis. So the upper lid starts covering the iris. So the millimeter of iris which is covered by the upper lid is supposed to be one of the point in the scoring system. Then inter-incisor distance, then length of the time of upward gaze can be maintained by the child, and FEV1. So these are the 5 points which tells us regarding how is the severity of neurotoxic manifestation of the snake bite. There is no role of Glasgow Coma Scale. So as per the National Snake Bite Scoring System, we assess the child and decide regarding the further management of neurotoxic bite. These patients usually need ventilatory support. The pharmacotherapy with anticholinesterase such as neostigmine 0.5 mg per kilogram with atropine 0.05 mg per kilogram. The starting dose is usually 0.5 mg per kg, but afterward the dose is titrated as per the response. Neostigmine test, some people do it. Neostigmine test, also called the tensilon test, but usually it is commonly not advised. because we don't have time. The time is very important in management of snake bite. Fresh blood, fresh frozen plasma cryoprecipitates may be used in severe hemotoxic manifestations. ARF can be treated as per the protocol. ARDS and respiratory failure can be managed by ventilatory support. Viper bites are associated with capillary leak and can lead to hypotension and shocks. So shock should be treated as per the protocols. Reporting, and most important is we must report these cases to health authorities. Now we have seen that the incidence of death is around 11 to 14,000 per year, but these are supposed to be very low values because most of the cases of snakebite are not reported. Even envenoming are not reported, that even the death are not reported. So reporting to the health authority very important. There are some preventive strategies for snakebite. One is don't go barefooted in jungles and farms. Avoid night walks in jungles and farms. Don't keep the stale food stock in home because rodents are attracted toward the stale food, and then snakes are attracted toward the rodents. Rodent control is very essential. To sleep on raised bed and well-tucked nets, to use light and prod with the stick. Community education is very important. We must go to these tribal areas and tell them that they can have snake bite and they can have serious manifestations of snake bite. Try not to provide hiding places for the snakes. Ponds, water sources which inhabited frogs, toad, etc. and attract snakes should be avoided. And maximum 80% of the bites occur during June to September, which is supposed to be the rainy season. Now we come to scorpion bite. Scorpion bite again is common in tropical countries, very common in the rural and coastal areas of Maharashtra, Tamil Nadu and Bihar. There are 19 species which are reported all over India. Two are poisonous. One is called as the red scorpion. The name is Mesobuthus and Tamilus, and black scorpion, that is Palmelius swammerdami. Exact incidence not known, as many bites are even not reported as we have seen in case of snake bite. Case fatality is between 3 to 20%. These are the two. One, that is Palmanius swammerdami is the black one, or the black scorpion, and then Mesobuthus stimulus is the red scorpion. Mechanism of action of scorpion venom is that venom contains mixture of neurotoxic materials, proteins, polypeptides, toxalbumins, and then cardiotoxins and cerebrotoxins. All of these have an inhibiting action on calcium and potassium dependent channels, and they open the sodium channels, leading to autonomic stop. Usually the child presents with profuse perspiration. Very classical presentation is that the history of either snake bite or not, but the child presents with a cold clammy extremity, tachypnea, profuse perspiration, excessive salivation coming from a farm. They have mydriasis, they have sometimes vomiting, lacrimation, frequent passage of stools or urine. Priapism. Priapism is supposed to be one of the clinical manifestation of scorpion bite. Sometimes the child can have seizures and encephalopathy. Myocarditis and congestive cardiac failure are commonly seen. Pulmonary edema is also associated with serious manifestations. Occasionally one can get pancreatitis and acute failure. Priapism is one of the common thing. There are some scoring system as per the priapism also, which indicates a scorpion bite. There are four grades of scorpion bite. One, if there is only just a local pain or swelling. Second, if there is sweating, vomiting, cold extremities, shivering, and priapism. Cold extremities, remember, by far is the commonest presentation. They absolutely present with cold and clammy extremity. And the parent says that he was all right and he was playing in the bushes and suddenly came running, crying, and suddenly became cold and clammy. Grade 3, any one of them, either hypotension or hypertension, myocarditis, pulmonary edema, or encephalopathy. And grade 4 is two or more of the above signs. Diagnosis is mainly history. Usually investigations are not same. So serum amyloid and LDH and lactic acid may be raised. ECG may be done if we are suspecting myocarditis, and echo can be done if you have facilities available. Management can be classified into either local treatment, systemic treatment, or specific anti-scorpion, anti-venom, which is available. Local treatment, ligature at the site should, but the important point again is should not be very tight and should be released in the intervals. Some people say that ligature should not be tight. Wounds should be washed with KMNO4, apply ice at the site. Again, immobilization technique, immobilize the limb as we immobilize in cases of fractures. If the pain is very severe, some people inject 2% xylocaine at the local site, give tetanus toxin. If the patient has got the systemic treatment, one can give oxygen. The drug of choice is prazosin. It's an alpha blocker and literally change the management of scorpion bite. 30 milligram per kilogram is given as stat, and then one can repeat if needed after 3 hours. Treatment of hypertension. If the patient is in congestive cardiac failure, one can use digoxin. If the patient has an associated pulmonary edema, then one can use furosemide. Aminophylline also if the patient has got bronchospasm and congestive cardiac failure. Supported treatment. Previously, people used to use something called a lytic cocktail like chlorpheniramine, maleate, promethazine, but now it is not used. Some people use glucose insulin treatment. And these are the specific treatment that is scorpion antivenom which is available at some places. So the take-home message is, though snake bite is common in India, two-thirds of the snake bite are non-venomous. So we have to tell the parents to relieve the anxiety and tell them that mostly this is a non-venomous snake. Big four are the common one, like we have seen: cobra, crate, saw-scaled viper, Russell's viper. Clinical suspicion is a very important thing, as we have seen that EMNS, that is early morning neuronal shock, is common with snake bite. There are certain do's and don'ts which must be kept in mind. ASV is the key in management, and even if the patient gets anaphylaxis, it should be continued after the treatment of anaphylaxis. Late manifestations are common, and hence early discharge should not be denied. The late discharge policy should be kept, especially Russell's viper. Scorpion bite, prazosin is the drug of choice.